Pune-based Genova Biopharmaceuticals, a subsidiary of Emcure Pharmaceuticals, is working on India's first mRNA-based vaccine for COVID-19. Genova has received funding from Department of Biotechnology and plans to start Phase 1 clinical trials in October 2020.
For COVID-19 vaccine, Genova is using next generation technology which combines mRNA and adjuvanted nanolipid carrier. This vaccine will be very low dose injectable, sustained release due to its self-amplifying mRNA platform. This will ensure safe and efficacious vaccine.
The advantage with Genova's mRNA vaccine is that it is rapidly scalable. So Genova can tap into the vast specialized nanoparticle capacity that has been already created at Emcure sterile parenteral sites to make close to 200 million doses. Additionally, our team is already partnering with different OEM manufacturers to install 1 billion doses capacity.
Led by the visionary founder, Mr. Satish Mehta, who has given many innovative and first in India products to the country. Emcure is committed in its fight against COVID and is working towards Swasth Bharat, Atmanirbhar Bharat. Jai Hind!
So welcome to the second edition of the Maternal Near Miss Lessons Learned program with AMOX and with medical grant from Emcure Pharma and Inventia. So first of all, I would like to introduce the convener for the program, Dr. Pragati Khalatkar. She is a gynecologist, obstetrician and sonologist, director of Khalatkar Hospital for the last 20 years, secretary Menopause Society, Nagpur, past president, NARCHI, national coordinator for Saath Saath IAP Foxy initiative, and her special interests are high-risk obstetrics and balloon tamponade in OBGY. Dr. Pragati, thank you very much for being the moderator of this program. I pass across the con to you to take it ahead. Thank you.
Thank you, Dr. Session. Thank you, Mr. Session. Thank you for nice introduction. I welcome you all to this session of series of Maternal Near Miss Lessons Learned Part 2 on sepsis. Near miss has always been very close to my heart. You know, we obstetricians treat the patients and we deliver them and we send them home and the story ends here. But maternal mortality is one of the very, very sensitive issues. Whenever there is any mortality, you know, the obstetrician has to pay a big cost for that mortality. Her name, her fame, her practice, media, so many questions are raised. But simultaneously, she also has so many near miss cases which she has dealt so well. But they are never discussed. So, the idea of having a webinar, web series on near miss was discussed with our president, Dr. Nandita Palshitkar. And she so willingly gave me, "Ha Pragati, we have to do it and go ahead and we will be doing this web series." And so, we have done our first webinar on placenta accreta spectrum on 5th of August, and today is the second one. And I hope Madam has joined, Dr. Nandita has joined. Has Dr. Nandita joined?
No, Madam.
No, can't see her.
Achha. So, I think we should move ahead and I will invite our chairpersons for today's webinar. And as Madam will come, we will just revert back to it. So first I invite Dr. Kanti Bansal, who is Director of Safal Fertility Foundation, Ahmedabad. She has distinction of producing IVF babies of Gujarat, first single mother of India. She has published 12 books on infertility, including Foxy and ISAR publications, peer reviews for JOJI and JRSCB. She is editor for European Journal for Endometriosis and president of Gujarat chapter. She was managing committee member, organizing chairperson for UISAR, chairperson for Endometriosis Committee, and so many other conferences. And she has several national and international articles and papers. So I invite Dr. Kanti Bansal as a chairperson for today's webinar on sepsis. Our second chairperson, Dr. Lakshmi Srikhande, my very dear friend. She is medical director for Srikhande Fertility Center, Nagpur. She is Chairperson designated for ICOG 2020, Vice Chairperson ICOG 2019. She is National Corresponding Editor for the Journal of Obstetrics and Gynecology of India. She was Senior Vice President for FOXI in 2012, Patron and President of Vidarbha Chapter ISPAG. She has received Nagpur's Ratna Award at the hand of Union Minister Shri Nitinji Gadkari, and she has received Bharat Excellence Award and received Merudara Unsotia Award as Best Committee of FOXI. And here I hand over for further proceeding to the chairpersons.
Thank you, Pragati, for that kind introduction. At the outset, I must compliment you for coming out with this initiative on near miss cases. This is much needed by we all obstetricians. Now, without wasting much time, I invite our three eminent experts who are here today to join us, Dr. Geeta Arjun, Dr. Sheila Mane, and Dr. Poonam Shivkumar. I request Dr. Kanti Bansal to introduce our first expert. Dr. Kanti, unmute yourself. Kanti, unmute. Yeah.
Thank you very much, Amox, Nandita Palshetkar, Dr. Lakshmi, Dr. Pragati, and MCure, and Science Integra. Good evening, dear friends. We are going to have a very exciting panel today, moderated by our Pragati, and the first panelist for this is Dr. Geeta Arjun, and she is the graduate of none other than Madras Medical College, fellow of the American College of Obstetricians and Gynecology. She is the director also of EV Kalyani Medical Foundation, and she is also author of many books. Welcome, Dr. Geeta.
Our second expert is just Professor Sheila Mane. I must say that she doesn't need any introduction, but for the benefit of our participants and just to place on record, I am telling you only the few salient highlights from her CV. Professor Sheila was the organizing secretary of AICOG 2019, which was held at Bangalore. She was Vice President FOXI. She was formerly the chairperson of Safe Motherhood Committee of FOXI, past president Bangalore Society. She is ex-professor of Dr. B.R. Ambedkar Medical College of Bangalore, and she has many achievements. Currently, she is the advisor for Adolescent Health Clinic at the FPAI Bangalore. Many publications to her credit. She has authored many books. I invite Dr. Sheila Mane to this panel discussion. Third slide session.
Thank you, Lakshmi. Thank you for those kind words, and nice to see all of you, Nagpurians. I feel I am in Nagpur because I am a Nagpur product.
Pragati, me, Poonam.
Yeah, I am a IGMC product, Nagpur product.
Session, Poonam ka slide dikhao. Kanti,
so
go ahead.
We have Dr. Poonam Verma Shivkumar, and she is professor and head Department of Obstetrics and Gynecology, and her fields of interest are gynecological oncology, and she is a member of several esteemed organizations like National Quality Assurance Cell, GOI, CEU, MGIMS, Sevagram, and Anti-Ragging Committee. She is also executive members SWGS and FOXI. She has plenty of publications, 43 in various international and national journals, and also given several lectures at the national as well as international level. Dr. Poonam Verma, welcome you.
Yeah, now Pragati, you can start with your case-based discussion because we really don't want to come between you and the audience.
Yes. So, thank you so much, Dr. Kanti and Dr. Lakshmi. Today I'm so pleased that I'm having three important pillars. Progress Lady. The Progress series of conference by Dr. Geeta Arjun have been a really a teacher or guide for so many working obstetricians all over the India. I used to attend from 2005 to 2017 every alternate day. So she's a progress lady then, and really we are following all what we learned in progress. Then our PPH lady, my God. PPH, thy name is Sheila Mane. Kahin bhi PPH, if you speak of, so Dr. Sheila Mane. And she has been taking so many workshops and training us in managing all obstetric emergencies. That's why our maternal mortality has come down, I can say, because many of workshops have been so hit and so liked by so many people. And UBT lady, she's working for UBT, and Dr. Poonam, she's working for UBT.
PPH bundle.
PPH bundle, UBT PPH bundle. I was just sharing the screen, that's why I just lost. Yeah. So here I welcome you all for today's panel, and just wanted to say we are very lucky to get one ICOG point was granted for our today's panel. So just, I'm thankful to Dr. Parag for doing this honor to our program.
I think ICOG credit points, now webinars are gaining so much of importance. No, Lakshmi?
That is why we are giving to have maximum attendance.
I know.
Just a minute, I'm just sharing.
Yeah, take your time, no problem.
Mr. Session, I'm not able to see.
Santi, Ahmedabad is cool, huh? How is Ahmedabad now?
Session?
Quite cool. It's raining a lot. It's raining a
Oh,
lot.
Session, Pragati madam ko help karo.
It's a pakoda time for us.
Yeah.
Pakoda and chai.
Yeah, I know. Chai and pakoda.
Session, I'm not able to see all the participants along with, I could see only madam. Session.
Right, because we have selected a different mode of watching.
I'm not able to see all, at least few participants. I'm just able to see
Please
slide.
click on show thumbnail video.
Pardon?
Please click on show thumbnail video above, where you are able to see all the at least a single participant above that.
About that, what?
Gallery view. Press on gallery view.
Yeah, correct.
Okay. This have to be.
Even when you will screen share, then you will be able to see the other participants.
Yeah, but screen share. Okay. Again, I'm not able to see others until unless I have eye contact. I won't be able to.
Yes, ma'am.
You have to be open your slides, then share it.
It's lying. Okay. It's.
Come to the Zoom and share and select your presentation.
Now play.
Yeah, double click.
But I can't see others also too simultaneously. I wanted to see all my panelists as well, no?
So you have to be put on the gallery view. Can you see the right hand side speaker view, gallery view?
There are
speaker view. Yes, speaker view.
Yeah.
Now it's done, I suppose.
Okay.
It again goes off, huh? Mm-hmm.
And when you are sharing the presentation, so you can't able to see others. Select share your slide.
You won't be able to see spelling.
No, we can see. I mean, it comes one after another in the gallery view.
Otherwise, we are not in contact with them. Aisa ho jata hai.
As a moderator, she has to see the panelists.
We should have eye contact with them.
Yeah.
So Pragati, if you put the share slide,
just put on the gallery
share slides, and you will see all of us on the side. Just share slides. Share your screen. Once you share your screen, you will be able to see all of us on the side.
Yeah, I'm sharing.
But we are not seeing your screen.
Yeah.
Now you will see all of us.
But now the screen is shared, but now all are seen, but your screen is shared.
Madam, may I request you to just go down and open the PPT in the bottom right corner? Bottom right, madam.
Yeah. Yes. Now it has abhi aaya hai. Fine. Yes, now it's fine. Okay. Chalo, that's it. Okay, chalo.
I think we should have this at the top, we are all seeing, so the slides are not viewed properly.
That's only for us, Kanti. The rest of the participants will be
they can see. They can see.
Okay.
So, near miss, 830 women die daily globally for consequences of labor or birthing. And it leads to a big impact on maternal mortality, and for that sake, for any country. So, this is a scenario which is prevented, and if a patient, and this is the case of converting a maternal mortality to near miss. Such a happy family, a happy baby, and it adds not only to the family but to the country and to the global scenario. And to bring down maternal mortality, we all have added a lot by converting all our maternal mortality cases to near miss cases. So advantage of investigating near miss events are, near miss are more common. Near miss cases yield valuable information about severity of morbidity and mortality. Investigations are better as women survive, and all near miss are free lessons and opportunities to improve our quality of services. And so is here this webinar on maternal near miss lessons learned on sepsis. So maternal near miss is a woman who survives life-threatening condition during pregnancy, abortion or childbirth within 42 days of pregnancy termination, irrespective of receiving medical or surgical interventions. And sepsis is a response of body to an infection. And when this response increases, it leads to peripheral and circulatory decompensation, or its body is not able to maintain adequate perfusion. It is known as sepsis. And this sepsis can be a primary cause of mortality, or it can become a superadded cause for the other causes and lead to a patient to succumb to sepsis. So sepsis is infection with systemic manifestations. Severe sepsis is sepsis plus induced organ damage or tissue hypoperfusion, and patient is said to be in septic shock when there is persistence of severe hypoperfusion despite of fluid replacement. So my first question to Dr. Geeta Arjun, what are clinical features pertaining to infections in pregnancy?
What are the clinical features? Well, I'm going to just specifically talk about the clinical features of 4 or 5 situations which are going to lead to sepsis in obstetrics. It's not every infection that's going to happen. And I think one of the commonest things that we are going to see is urosepsis. That is, as a woman comes with urinary tract infection or ignores it till it becomes pyelonephritis. And because we know that, and we will come to, I think, pyelonephritis later on, but that is one of the serious causes of sepsis in pregnancy. The other thing is, of course, septic abortion, because these are women who either don't seek the right person or get it done in a place where they do not have the facilities. So septic abortion is another one. So infections, as far as viral infections are concerned, most of them are okay. They don't lead to severe sepsis and sepsis shock, except H1N1. And I think the pandemic in 2009 showed us that H1N1 can be extremely dangerous as far as pregnant women are concerned. And then there are situations in day-to-day obstetrics, like when you have PPROM or ruptured membranes, where you can go in for chorioamnionitis and unless you're on top of the game, unless you are dealing with it on the spot, if you don't take care of it, the mother can either be a near miss because of severe sepsis, or in severe cases, it can also be mortality. So these are the situations in day-to-day practice of obstetrics that most obstetricians will come across. These are the situations, these are the infections we'll have to deal with. Because there are going to be 1 or 2 rare cases, but I don't think all of us have to get so worried about those. These are the day-to-day cases which will lead to sepsis.
Very true. What are the risk factors for sepsis, Dr. Sheila Mane?
Now, as Dr. Geeta has told about certain conditions, as PPROM is, or PPROM mainly, I mean, if it is not treated in time, as well as PROM, and how the patient is managed during labor, as well as the already present if there is a urinary tract infection. If she is a referred case and we are doing an emergency cesarean section, most of the time in institutions we do get referred cases. And if there are associated comorbidities, like she may have diabetes, even obese patients are somehow more prone to infection. Okay. And some anemia is such a common, and already if they are from low socioeconomic status and they have associated anemia, definitely there will be, these are the patients who are more prone. Now we do a cesarean section, and cesarean section is on the rise unless and until all precautions, all aseptic precautions are taken, including from catheterization. Even that can also lead to sepsis. So any surgery, whether emergency or elective, cannot be taken as likely. And if any third stage complications like retained products of conception, manual removal of placenta, all this can lead. Otherwise, apart from the conditions which Dr. Geeta has mentioned, even a bacterial vaginosis, if the patient has, should be ruled out during pregnancy, and other things. So these are the things which should be looked into. And a history of previous pregnancy also should be taken into consideration. Any history of fever during this pregnancy or the urinary tract infection, all this will definitely help us to see that which are the predisposing factors.
May I just add one more this thing as risk factor. We used to say that women at two extremes of the weight range, either very underweight or obese. But I remember when I started practice several years in 1981, it was very common to see women who came in at 55 kilos, 60 kilos. That was very common. By the time I retired, it was 65 was the beginning weight. I mean, you just see the huge change. So now more often than not, sepsis is more common in the obese women. And
yeah, that's what I said.
Yeah, we are talking India, where 1 out of 5 women is obese now.
Yeah, yeah.
Difficult to treat as well.
There is something which is very important and which we should not forget nowadays is what is the risk is iatrogenic. You see, all
iatrogenic
into the most of the PHCs, CHCs and all, there's no infection prevention practices. That's the crux of having infections in number of cases. So no, you see the way catheters are put, you see the way dressings are changed, you see the way things are being done. You must see emergency cesarean section and they will wash hand and come and operate. So there is no proper hand washing, there's no, so this is something which is very important, and we blame the patient that she's from low socioeconomic status and so she is not, she's
facility also matters. Yeah.
You must look into that. Your all infection prevention practices should be at place.
This is very important. If it's going through us, if we are giving infection, is something which is really not pardonable. And
I think Poonam, if we now we have the Lakshya initiative, and I must tell you, I mean, if the visits by the seniors and they do visit PSCs, you are already working at a periphery level. You know that at least in Karnataka, I know that this Lakshya initiative has really made lot of changes, you know, the way now it is, at least I must say in public sector, okay. And I must say in private sector, we know that Manyata initiative with Foxy also focuses on that, where they have those 16 clinical points, okay. But still there is a long way to go, as our country is, you know, that very vast.
Nowadays, in Lakshya initiative, they are putting up lot of posters and this thing. But you see, it's not enough.
Not enough unless and until it is practiced.
One thing we can say in this COVID era, that people have learned how to be more aseptic practice. They have learned because of coronavirus. Hand washing has really become very common. All our staff keep on using sterilizing themselves. So at least somewhere it is curbed some infections because of social distancing, as well as using masks and the things. So why it is difficult to identify sepsis in a pregnant woman? Does it affect for diagnosing a patient who is having infection, physiological changes of pregnancy? Yes. Yes, Dr. Geeta?
Yeah. So there are already physiological changes in pregnancy which can be, which may confuse the issue. As you all know that you've already put up the slide. But there are subtle changes which you must look for. And for me, as far as I am concerned, and I have taught this to all my doctors, the first and foremost thing that will change, that you have to watch for, is tachypnea. I think if you walk into a woman's room and her breathing is more than 22, her rate, respiratory rate is more than 22, you better get your red flag up, because that's going to be the most important thing. Whatever else, of course, blood pressure, because you know, you can have Indian women with a blood pressure of 100/60, which is normal for them. But nobody is going to be breathing at more than 22 breaths per minute, you know. So that is, I think, one of the most subtle and the most important things, because all the other things can, because of the physiological change, can, and you know that pregnant women have a decreased immunity, so they are more susceptible to infection. But once you get this change, you know that you're dealing with a woman with sepsis.
This is the take-home point. The patient tachypneic is giving you a red sign. What diagnosis?
Sana, somebody has to unmute, I think.
Yeah, mute.
Yeah. Sorry, mute. Yeah.
So, as a physician, we should have high index of suspicion. We should identify high-risk patients. We should. Are there any tools, Dr. Poonam, to identify sepsis?
See, Muse tool and QSOFA tool have been the quality tools which we all have been following for sepsis. And you have already put the slide. QSOFA score is really very good, because whenever you find it more than 2, you say that there is very high risk of mortality. So these are 2 tools which are being used universally. And one important thing what we have to know is that many women who's pregnant is having isolated tachycardia. So you put your hand on the pulse and you find that the pulse is increased. This has been a very old teaching and it goes till now. Any tachycardia which is unexplainable, the first thing is you have to think about sepsis. So this is Muse tool and QSOFA tool which are being used.
That's so easy tools. Just looking at the patient without any investigations in your hand, you can have a suspicion and you can start working about it, right? So, what is etiology of obstetric sepsis and what are the causes, Dr. Sheila Mane?
Now, obstetric sepsis, like if we look at the causes, like, you know, it may be systemic as well as it may be local also. Systemic, we said that urinary tract infection, urinary sepsis, which is so common. Then another thing is like chorioamnionitis, okay. Then we have septic abortion, okay, where could be retained products of conception is there. And the other associated diseases like we know now the patient may have pneumonia or may have a sari-like picture. It could be even due to bacterial or viral like influenza. Okay, influenza A is H1N1. And the other conditions, even postnatal also we have to take into consideration. Even there could be wound sepsis, cesarean wound sepsis, as well as the episiotomy infection will be there. And other associated causes also, once Dr. Poonam mentioned about tachycardia, you know, which is so important, you know. If you are really not able to find out any obstetric cause, you will have to go out of the box and think whether there are any other infections, even a cholecystitis, because we do see patients coming with cholecystitis during pregnancy nowadays. As we are saying, Dr. Geeta mentioned about obesity also, that way cholecystitis is also, seen very often. And other things are mastitis is again postnatal, okay, and a puerperal sepsis. But chorioamnionitis, if we think of PROM, you know, which is again the another common thing which we have to think of, which Dr. Geeta mentioned about tachypnea, and I really agree with her, and tachycardia, which Poonam, because these 2 simple things will help you, you know. So whatever we say, the routine examination of the patient, okay, is so important. And which I think the newer generation, you know, is going away from that, I must say, you know. It is becoming more of a technological, but that is how we have been taught, you know, everyday rounds and looking at these things and putting it on paper, you know, as a house surgeon, as a registrar, as a lecturer. So these are the very important things.
Can I please ask the panelists who are not on mute?
Yeah. I think that somebody's phone is...
mute yourself.
The session, please look into the matter. You please mute others.
Technical team, please look into the matter.
So, Sheila, what you had said about the next generation, I think I'm going to say this because there must be some young people watching. When you walk into a patient's room and she's got fever, you've been called in because she's uncomfortable, go and start checking her pulse rate. Smile at her and say that you're checking her pulse rate and you don't want her to speak at that time because you're counting. And while you're doing that, you're looking at her and you're counting her respiratory rate. Because if you tell her, wait, I'm going to check your breath, I'm going to count your breathing, she's either going to start panting or she's going to hold her breath. Okay. So I think these are very simple clinical things, but it helps a lot because any number of times I've walked into the room where the other doctors have already seen the patient, have not picked up on this subtle thing, the tachypnea. So these are, as you said, we rush into all the other things like doing other tests, but clinically you have to, yes, Poonam.
Very important thing, ma'am, what I think she has already shown is anemia, because this is the crux in our country for having infections of various variety. Anemia is one of the major cause. It was and it is still. I mean, if we look into our women, more than 50 to 60% are anemic. So I think that is also something which we need to really discuss about how we look into it and how from adolescent we take care of it so that the pregnant women is.
Sure.
Yes. And patients speak about her condition. The way she will tell ki I have a pain. Her way of telling कि मेरे को पेट में दर्द है, it gives us the severity of pain and what she's having. Even her vomiting, nausea, if she says just nausea, it gives us a like, my God, is she having UTI? Though she's not giving any urinary complaint. So how the patient speaks, it gives us an input that she is really, something is going on wrong. So now how do we classify sepsis? Dr. Sheila?
See, now when we have to classify sepsis, it will be in 3 categories. Okay. So first, the patient will come with the signs and symptoms of fever and which is about mild to moderate. Next, you will have a picture of a SIRS, that is a systemic inflammatory response syndrome. And in the last stage, the patient goes into septic shock. Okay. So it goes into 3 stages. In early stage, then the middle stage is again a SIRS, and then there is a severe sepsis which leads to septic shock. So what happens is, if we have not diagnosed it early and treated, it can definitely progress further, and there will be multi-organ involvement which will again worsen the situation. And in again septic shock, you will have 2 phases, the warm phase as well as the cold phase. And once the patient goes into cold phase, because there is a endothelial damage, the fluid is leaking out of the vascular membrane, and the patient will have hypovolemia, and then she will have a cold stage. So it is very important that it is being diagnosed early. Okay. And all the other factors which we look into, that is depends on the investigations, where the counts will be raised, the total counts will be raised, tachycardia will be there, tachypnea will be there. Okay. And temperature, as I told you, early stage it will be more, and later stage there will be hypothermia.
So we should not let the patient go into irreversible shock. Our treatment should be, we should be so vigilant that we pick up the patient, and when she is going into sepsis, she is going into severe sepsis, we should start treating her. No matter the reports, we should start. If we find patient is febrile, we should put up antibiotics, send the lab, but don't wait for the lab reports and start doing all your management. And if she is showing signs of hypoperfusion, just load her with all crystalloids to prevent shock setting in.
Also to add on, the classification of sepsis in general is this. Every specific disease, it has a different classification. So if you talk about septic abortion, you have to grade it. Grade 1, grade 2, grade 3, grade 4. So I think it's very important that we look into it in such a way that before going into different grades or going into septic shock or whatever, the crux is that when infection occurs, treat it there and then, whether you use your bundle, whether you identify by Muse, whether you do SOFA scoring, but treat it at grade 1 stage and do not let it go.
Right, very true. So what diagnostic modalities will you use in antenatal patients with history of fever more than 3 days and not responding to oral PCM? and first generation antibiotics?
What does she have that she was on first generation antibiotics?
Yeah.
I would not start any woman on antibiotics because she had a fever. What was the reason that she's just come to you?
This patient has come. She was taking treatment from some other doctors, and
she's pregnant. She's got a fever, and she's on some antibiotic, right?
And she was not relieved, so then she has come to another doctor.
Right, of course. And if she came to me, first of all, I would stop the antibiotics. The first thing I would do, because I need to know what it is for. If it's just got a fever and only 3 days, chances are it's viral. Then we have to start looking at her symptoms. Where is it? Where are her symptoms? Does she have dysuria? Because if she is not anything to do, if she is not intrapartum, the commonest things are going to be a viral infection, viral fever. It could be a bacterial infection, throat, lower respiratory infection. So we will have to start looking at her symptoms. Once we start, and this is one thing that I would strongly urge doctors to think about, because COVID is giving us major lessons, but because we have lost, we have not learned the lessons that we should have. Giving somebody an antibiotic because she has a fever is, I think, one of the worst things we can do. We have done a terrible thing to our children and grandchildren, because now we are dealing with antibiotic resistance on a global scale, on a massive scale. So first check her symptoms, and then if I would first of all go through a history very carefully, and that I would examine her, and if she has any abdominal pain, if I'm thinking of cholecystitis, am I thinking of lungs, does she have a viral fever, does she just have a sore throat and viral fever, does she have a UTI? I would start with that before I go in for any diagnostic modalities. That's not going to be my first thing. If she gives specific symptoms, I will start my diagnostic modalities based on those symptoms.
Yes, sir. So how will you proceed? What investigations will you do for this patient?
So I'm just going to continue the paracetamol, do a head to foot examination. Again, a big message. Please examine the patient head to foot. You are not just a pelvis doctor. Examine her completely, check and see where the problem is. If she has just a sore throat and a cough, I would treat that symptomatically. If she has a UTI symptoms, I would do a urine culture and sensitivity. And because she's had the fever for 3 days, if she is having dysuria, I would start her on empiric antibiotics based on the urine routine test. If she has pus cells, it's loaded with pus cells, I would start her on an antibiotic, and most probably I would start her on cephalexin, and that would be, especially if she's in the first trimester or second trimester. I wouldn't start her on anything else right away.
Yeah. Dr. Sheila, when will you admit a patient who comes to your OPD, ANC patient who is giving history of fever, and when you feel like making her indoor, at what could be the signs or what could be the lab reports which will make you think to admit the patient?
See, many patients come with fever and sore throat, we need not be admitting. Yes, we will, investigations which we have already spoken, about CBC, it may be raised about 12,000 or some urine infection, all that can be treated on an OBT basis. But suppose the patient has a urinary tract infection, she is getting fever, she is getting chills, she is not responding to your oral medication, then it is better to admit her, because we know that urosepsis, because if it is not treated properly and if it is there for a long time, okay, she may need IV antibiotic. Another thing is, if we are suspecting any viral fever, okay, if we are suspecting any viral fever, I think it is better to admit the patient, because we know that how soon they deteriorate. For example, you take H1N1, even in dengue cases also we know that the platelet count goes down so soon. So we will have to monitor them. Another thing is respiratory infection. Now, if it is respiratory infection and on clinical examination, yes, there is tachypnea and there are findings, okay, that there are adventitious sounds or something, we will have to admit these patients and treat them. Now, another thing I will know, I mean, PPROM, the management is totally different. We are not talking about that. But if it is a septic abortion, again, the patient has febrile morbidity, tachypnea. I mean, you can just go for Q-SOFA score and decide the score. If it is more than 2, definitely we will have to admit her and treat her.
Yeah. Dr. Poonam, now if a patient is admitted and if you find that she is she's showing signs of, you notice this hypotension is there, she's tachypnic, and we find signs of shock. So how will you manage such patients?
So once we see, as Madam has already said, Dr. Geeta has said that we have to look into the history, you have to do an examination, and here when she is in septic shock, there are 2 shocks she is going through. One is endotoxic shock and another is the fluid shock, which is already there. So these patients are more critical. So 0-hour management is done, especially in the septic bundles which have come up. And that management is you manage the shock and start the antibiotic simultaneously. Because unless you give antibiotic, this woman is not going to respond that well, only by treating her by crystalloids and all. So you have to really look into what kind of antibiotic do you start. Remember that this is an era where we have very high antibiotic, the very higher antibiotics are there. But then you also have to know that antibiotic resistance is also coming. So do not hurry up in going on to the higher antibiotics very quickly. The investigations give you a pretty good idea how you go ahead with the treatment. Why? Because you see there are a set of blood investigations, there are a set of urine investigations, and there are a set of several other investigations which you have mentioned. So giving these antibiotic is also extremely important, because supposing she is having hepatitis or she has some liver and you give hepatotoxic antibiotics, it's going to create a problem. There are several evidences, like let us talk about PPROM. We say that there was an Oracle trial which said that erythromycin has to be added along with whatever antibiotic injectable you are adding. So Oracle trial tells you that. So plan your antibiotic, look into her all parameters. Liver function is disturbed, kidney function is disturbed, blood coagulation is disturbed, and accordingly you have to treat. Also, it is very important what is the cause. You keep giving antibiotic and you see that there are products of conception which have septic focus. So unless you remove them, so you have to look into the reason, the root of it, the cause of it, and you have to treat the cause.
I think rightly said, Dr. Poonam. Another thing is, some investigations, as we know that we manage these patients in HDO, at least serum lactate levels, if we are suspecting sepsis, I think we must do that, I mean, I would like to just tell the delegates also. And another thing is, yes, procalcitonin, okay, which will tell us about that. And CRP in certain cases, which will tell us that these patients can go into severity, and antibiotics is the main goal, definitely. That is not the thing. So I think these investigations also one should not forget once we are suspecting.
And physicians also have to know what is ABG and what is the interpretation.
What is the interpretation?
At least we should know what a patient is going at.
Since our obstetric ICU and HDU have started working, probably we are giving more importance to that. So that also is very important, that we know the interpretation. Just by doing ABG, it's not this thing. You should know if it is acidosis, what you have to do. Is it ventilation? Whatever. You have to understand.
We also don't so frequently order blood cultures. HDU people, they frequently keep on sending blood cultures, and we are not in use. We generally send urine cultures more frequently than sending blood cultures whenever we get our patients. So we should do blood cultures, serum lactates. If patient is in shock, that is very important indicator that she may go in septic shock. If it is more than 4 millimoles, patient is going towards shock. This is a very important indicator. And as Madam has said, ABG, we should at least know what are the reports. So we should understand how the things are managed. So,
Pragati, before we just go on, because now you've brought in blood cultures, can I quickly just run through?
Yeah, sure.
Because, see, we have to understand that there is a whole way that it's going to progress. Okay, it might happen rapidly. But first there's an infection, then there's a bacteremia. then, and because of the bacteremia, there is going to be an inflammatory response. Okay, you're going to have cytokines, and therefore you're going to lose a lot of fluid into the interstitium. So that's one thing that's going on side by side. The other side that's happening is vasodilatation. So therefore, you're going to have hypotension, you're going to have tachycardia, and then altogether, you're going to end up with a coagulation defect. Okay, so these things are going on together. So unless we can't just say, I'm going to do a urine culture, but I'm also going to do a blood culture. No, it depends on which part of this pathway she is on. So if she is getting to the point where she's dropping her blood pressure, you know that sepsis has set in. This is where you need to do a blood culture, not just for anybody.
Not for anybody.
No. I'm just making sure that the younger ones who are listening, that they know that there is a certain way this goes on, the way it progresses, and that's when you have to do it. And of course, yes, blood cultures are extremely important in a woman who's been admitted. If she's been hospitalized, she's sick enough, we need to know whether there's bacteremia. Yes, so I agree with you.
So fever profile is there. You know, you go in the graded manner. There's a fever profile in which initially you only do CPC, you do urine examination and all, and then you go on to LFT, KFT and all. Then you go on to blood coagulation profile and ABG. So it's a graded way.
Depends on the severity. Yeah.
Then do blood.
And I also say that when it comes to up to the point of ABG, there's no way I'm going to be dealing with that. Okay.
Yeah. The patient is either in HD or ICU.
Yeah, there's going to be an intensivist management.
At that stage, the patient is in ICU.
Obstetric ICU and HDUs are there, which have to be managed by obstetricians as per Laksh. So you have one.
Fortunately, there are very less obstetric ICUs or HDUs otherwise.
Fine. But that obstetrician who's in charge of the OB ICU should know about. I mean, I knew everything about ABGs.
Everybody may not know.
But I'm not saying, I'm saying that there should be a specialized person. The general obstetrician cannot manage.
They
should not be managed.
The line between us and ICU care, it's totally different. They are working.
When to shift from HDU to ICU.
And bottom line is shift the patient to ICU and keep on monitoring. Just that is it. So now we'll go to our first case. This is 25 years primary, 37 weeks, was admitted with complaints of abdominal pain since 2 hours. She had history of loose motion since 2 days and yellowish discoloration of eyes since 5 days. On examination, she was well oriented. Her pulse was 84 per minute. Blood pressure was 110/70. Pallor was present. Icterus was present. Per vaginum, she was 1 finger loose. 20% efface and membranes were present. Her blood group was B negative. Total counts were 15,900. Hemoglobin 9 grams and Australia antigen HIV were negative. So now how will we proceed in this patient with deep?
On examination, it is jaundice in pregnancy.
Yeah.
Right. So we will have to investigate her for jaundice in pregnancy. So we do a liver function test, then we do all other tests also, renal function test, as well as I think coagulation profile also we need to do, and CBC and all other things. And then we will have to see what is the cause, whether it is acute fatty liver of pregnancy, whether it is a hepatitis, or whether it is cholestasis which is leading to jaundice, and depending on that. So from the patient history and the investigations, we will know all that. Okay. And we will have to differentiate. If it is due to viral hepatitis, all of us we know that values of the liver enzymes will be very high. Okay. And uric acid may not be so high. If it is acute fatty liver of pregnancy, yes, enzymes are elevated, and there will be, yes, hyperbilirubinemia in all of them, and also associated hypoglycemia. Okay. Uric acid's level also will be high. So that is how we will have to differentiate it, whether it is acute fatty liver or hepatitis or some other thing. And then accordingly, we will have to manage. Now, all of us, we know if it is cholestasis, yes, we will have to manage accordingly. We give Udiliv. Then if it is any other thing, we will have to see, because if it is cholestasis, then we know that we don't go beyond 37 weeks of pregnancy. We have to see that bile acids levels are checked, because they are very toxic to the fetus, and chances of even sudden stillbirth and fetal hypoxia are common in them. Okay. Now, if we talk of viral hepatitis, yes, A is not so problematic as well as B, but certain hepatitis C, sometimes it, not so common. Hepatitis E, in some endemic areas, it is very common, but it is the most fulminant, the hepatitis C. and the chances, the incidence of maternal mortality is very high with hepatitis E. Okay, it is almost, we can say, up to 20 to 25%. And there are some of the study from, I think, Lady Harding Hospital, and where they have seen maximum, most of the cases in maternal mortality due to hepatitis E. Okay, so that is how we will have to differentiate what is the cause, and then accordingly we will have to take a call.
Very true. So her liver enzymes were raised, serum bilirubin was 11 milligram, viral markers were done, and it was hepatitis E positive. Coagulation profile was deranged, INR was 2. Her IV fluids were given, and syrup lactulose, syrup udiliv were given, 25% dextrose. As Madam has rightly said, this patient lands up in profound hypoglycemia. Labor was augmented with tablet misoprost, 25 microgram, but she landed up in seizure for thick meconium. Seizure went on uneventful, but on day 2, her dressings were soaked and there was yellowish fluid which was coming out from a wound side. It was copious in amount, it was oozing from wound side, and patient was deeply ichoric and disoriented. So
you know, the liver, I mean, the encephalopathy is more common, okay, in them. So even that can also lead to disorientation, because it can lead to encephalopathy. So that is the another reason. But I think what you're telling about watery discharge from the wound, right?
Yes.
Yeah. So whether that was due to ascites or anything, yeah.
So her LFT was daily monitored, it was deranged, bilirubin rise to 13, USD suggestive of hepatomegaly with ascites with abdominal wall edema. Culture of wound swab came positive for Acetobacter, sensitive to cefuroxime and tetracycline. Vitals were deteriorating and patient was shifted to ICU on day 3 with daily dressing, and supporting management was given. Exploration was withheld in view of hepatitis E, and daily dressing was done, and she was managed conservatively with antibiotics and ICU care, and gradually patient improved, and she was there for 20 days and then she was discharged.
Was she in DIC? No, she didn't.
No, her coagulation profile was fine, but she had ascites basically, and had copious amount of fluid discharge from her site of wound. So in such cases, disorientation was present, so this patient was going into hepatic encephalopathy. Yes,
so
Dr.
Two, three things I would like to add here.
Yes.
One is that this is a case of hepatitis E, which is the most fulminant, and it kills actually. There's a common management of all hepatitis patients, because basically it's the liver which is not functioning, and there are certain supportive management which we need to give. Number one is that we have to give very high carbohydrate diet, and we have to reduce on proteins completely. Fat is debatable yet, that you should give or you should not give, but a bit of fat is okay. Second thing is that vitamin K is mandatory in these cases. Third thing is that we have to give some kind of antibiotic which prevents the bacterial flora in the intestines. And previously we were giving neomycin, now we are giving amoxicillin and all also. So that is also very important, which will prevent hepatic encephalopathy. The next thing is that, be very sure that whatever you are giving her, if you have to give any antibiotic or anything, it should not be hepatotoxic.
Yeah.
So these are certain things. Now, try your level best to have a vaginal delivery in these cases. Why? Because vaginal delivery is still safer as compared to cesarean section. But when it is an emergency, then of course we have to do, and we should take the blood, and we should ensure that she can have PPH. So we should go prepared for that. So these are certain things I think it's very important. Lactulose you have written, we always give that. So these are a few things which I wanted to add.
This was a case who was referred to tertiary care center. My colleague has informed me, and they said they were doing dressing with those tetracycline, dressing with tetracycline, and that really helped. Daily dressing was done. So what role it had in correcting her hyperbilirubin, I don't know, but her wound was taken care and it works. Sometimes those
now they are saying it is antiviral also. I remember my father as a GP giving tetracycline to all his patients. Right, Dr. Geeta? I think.
Yeah. It's a common experience of all of us that although we say that systemic antibiotics are to be given, but the local antibiotic application in the infected wound does play a role.
Does play a role.
Even I heard one paper in a conference, they said about putting insulin infiltrations for wounds which are not healing.
Please don't do that. Please don't ever go away with this message that you can start giving insulin in the wound, because that insulin is going to get into the systemic this thing, because as you're giving it sub-Q. Please don't go away with that message.
Not this message.
Absolutely wrong.
It was right. A paper was presented. I was just mentioning that.
Pragati, that's because people might start
anecdotal.
Yeah, and I also am not sure I have come across any evidence for local antibiotics on wounds. I have not, as far as I know, wound treatment. I have not come across anything. Maybe there is, and maybe I will look for it after.
There are some literature. Some people have, totally abandoned it. Some have given it. But I don't know, a common experience, what we have seen, even if you remember, we used to use mercurochrome. So that lal dawa bola jata tha usko, Somehow we feel that, if you apply it all over, I don't know really, the experience has been, it's not in literature or research or whatever, but experience has been that they do have some kind of effect on reducing the pus discharge or something like that.
Poonam, you know that the human body is amazing. It will heal itself with mercurochrome or not, with tetracycline ointment or not, okay? And there's also, so we have to, unfortunately, in medicine, we have to stick to evidence.
I think, like that many experiences. I had a patient who was highly diabetic, post-cystectomy, bad wound, you won't believe. I really treated her with the slices of raw papaya, because it was so bad wound, so there are some anecdotal.
Yeah, absolutely. We agree that it should be evidence-based.
Yeah.
Yeah. Madam, I just wanted to know, how many of you remove primary dressing and do a primary dressing and do a secondary dressing for a cesarean patients? Or the primary one is only removed for stitch removal or finally?
Nowadays you are giving subcuticular stitches, no?
Yeah.
So even if you don't remove, you remove it on 7th day, cut the sides, it's all right. But the general concept is that 5th day you must change it.
5th day, yeah, that's what. We remove it on 5th
What's
day.
your question? I'm sorry, I didn't get your question.
I mean to say, once a patient scissor is done, so do you do primary change of dressing on day 3 or day 4? This is what I want to ask individually to all the three.
Okay, so as far as we were concerned, we put a single gauze on the mother on the as soon as she's done with the surgery, because we used to use strips. Even if you're using subcuticular, that's fine. And then the next day when she has her bath, it's removed. We never put it back on. If there are
you don't put it back after 2nd day.
No.
Okay.
No, there is no reason to put it back, because the moment the fibrin is formed, as it's healing, fibrin gets deposited on your incision. That way you can spit on that wound and it will not get infected. That's it. So you don't need to put anything. And she can bathe, she can do everything.
Okay, ma'am. You're removing on the 2nd day, you said. That's
really Pragati, 2nd day. Aaj kiya to kal nikal denge. Yes.
Okay. But my personal experience
is something which we have to look into, because evidences say that ideally you don't need anything. You can even spray over.
People use only a spray, yeah.
Only spray also. When I was in Riyadh, I have only used the spray. There were no dressings at all.
Exactly.
But you have to really look into where are you working. If you're working in the most rural area where people have been coming, with no bath for 3 days, with the dirt of, 1 mm all over the abdomen and this thing, how much ever you clean, So that you have to look into and decide,
May I say something there? The infection in the wound is not coming from the patient's skin. It's coming from the fact that you have cut open the cervix, uterine segment, and you're getting infection from the vagina and the cervix. It is not from the wound. It is not from your surroundings. It is from her. Okay. So we have to be very clear about that. Wound infections, that's where they come from. So, I mean, it's certainly everybody has to make their own call.
Some patients have so bad hygiene, so we feel
yeah, definitely. I think we find it
their hygiene level is too low. Few people.
The rule is that if you're having an
I am telling you, we did a trial where cefazolin is said to be given for
prophylactic.
Just before surgery, you give so one of my colleague, he did a trial because we were all fascinated by just single shot of antibiotic because our patients are poor and they do not have money to buy. So we did that, but results were not so good for us. Although the evidence says that it is very good. Results were like, some of the patient ended up in full wound dehiscence. And there was a burst abdomen, 2 burst abdomen happened during that period. So that time, we were really, we said
that is what, you say, that if there is associated anemia, other comorbidities and their background will matter. Yeah. Nutrition, hypoproteinemia, everything.
So we have used only 1 gram of 1 dose of cefazolin for all our cesareans, all our hysterectomies, and in our hospital, the wound infection rate was less than 2%. So,
ma'am, I think, it all depends also, how you bring that patient. Like, if these are elective surgeries, you let the patient take bath. Then while you are doing the surgery, you have taken all infection prevention practices. So all those things must be very good in Madras Medical College, and it's known that
Madras Medical College,
her own.
at your, so you must be like, ma'am, doing those things. But when these residents are there, and the number of times they are going and coming out and going out of duty, so those things make a difference.
And when there is a rush, there are so many emergencies happening one after another, right?
Yeah. So, is there any role of corticosteroids if a patient is near preterm, and if a patient is having hepatitis? What will be your say, ma'am?
For somebody who's preterm and hepatitis,
she has to land up in.
If she's 24 to 34 weeks, she should get corticosteroids.
Okay. And when we want to prevent vertical transmission to the baby, what are the prevention ways?
So the first thing is, as soon as you get, obviously every woman should be tested for HPS-AG. Yes. And if she is positive, then we check her husband's surface antigen. If he is negative, you have to make sure that he gets his injections. 0, 1, 2. In 2 months you give it, so that this is a rapid immunization. And then he can take his 6-month injection later on, but 0, 1, 2. Until then, you have to inform them that they should use condoms to prevent transmission to the husband. That is one side.
Yeah.
Then vertical transmission, the moment you know this woman has HPS-AG and you know that it happens intrapartum, this vertical transmission will happen intrapartum, and you can avoid it in about 90 to 95% if as soon as the baby is born, you give the vaccine and you give the hepatitis B immunoglobulin. It's as simple as that. And in spite of that, there is a small, about 9% of babies who will go on to develop hepatic issues later on. So so you'll be able to avoid it in about 90 to 95%. And this is something, it has to be on your chart, it has to be written down, she's HPS-AG positive, and because it's not just vertical transmission to the baby, it's not just transmission to the husband, it's transmission to your staff.
Yeah.
Your staff all have to be immunized at your cost, not at the staff's cost.
Exactly.
Secondly, universal precautions should be absolutely part of your hospital protocols. It should be just every nurse, the most junior most person who disposes of things should know that we have these buckets for different things and how to dispose them of. Yeah.
That is what they say, at least HIV, you need a more quantity of blood, but for hepatitis, it is 0.0004 ml, very minimal. Right. So one has to really take universal precautions and protect the other staff also. Right. So it's very important.
Very important. Yes. What are soft tissue infections leading to sepsis in pregnancy?
Excuse me.
So when we talk about soft tissue infections, if we are dealing with the we classify it into sepsis, which is happening because of the causes in pregnancy, or they are the medical causes, right? So when we talk about causes in pregnancy, we start from early trimester, so it's the retained products of conception which comes as the first, and then you come on to various number of time chorioamnionitis is there because of PPROM, and then you come on to cesarean section and their perineal wound infections, then you come on to puerperal sepsis, and that ends up in pelvic abscess and all those things like that. Number of times in septic abortion, what you will find is different kind of foreign bodies. They use hairpins, they use tree twigs, and we have removed what not from the abdomen of the lady once septic abortion. So those are the things which you have to look into, and other soft infection are medical infections like urinary tract infections and all.
Yeah, we will be coming to it later on. So this is another case with
rarely, like if you have handled the case, the patient had a postpartum hemorrhage and you have put in compression sutures, still the patient persistent having fever and all that, like there could be even anaerobic infection, and you can by ultrasound you will find that there is air accumulated in the myometrium, and then those patients again need hysterectomy. Those are also there, So wherever there is a more handling and chances of sepsis will be there. So that is also there, one of the things. Rare, but nowadays we do see so many adherent placenta cases, and then we do some conservative surgeries. So we have to really monitor them, even though we have done conservative surgery for sutures on the uterus. But we need to, because post-operatively they can still develop sepsis.
Yeah, when there is PPH, multiple handling are there, everybody is trying, and really sepsis, chances of patient can be saved of PPH, but sometimes these infections take over and we can have a vicious road. So this is a patient which with third gravida 3 para to 18 weeks, referred to a tertiary care center with diagnosis of septic shock with uterine perforation in shock. This was a transferred patient. And patient's condition on admission was she was toxic, tachypnic, pale, icteric, pulse was 130, BP was 80/40, and respiratory rate was 30, a full-blown shock picture. And per abdominal it was tense, guarding, rigidity was present, bowel sounds were sluggish, and on examination, PS examination, there was vulval edema with muddy discharge, Foley's catheter was in situ with 500 ml of hemorrhagic urine. On PV examination, uterus was 16 weeks, soft and tender. So this was a full-blown septic patient. So how will we proceed for such patient?
See, as what we are seeing from this, I think it's almost a full-blown sepsis, because in septic abortion also we will have grades where there is only parametritis and there is tenderness. So we can just give IV antibiotic, parenteral antibiotic and manage, or we can see a patient with a pelvic abscess where we may need to do colpotomy and drain that. Definitely, we have already started the management of sepsis, as these patients seems to be going in for 130 pulse rate, going in for septic shock. So we will have to start the ringer lactate infusion as well as higher antibiotics. Then we will have to get her CBC done to know whether she is anemic, because she may require, and also the coagulation profile will be also required, because endotoxic shock can also lead to coagulation failure. So then the last option is, even sometimes they need laparotomy also. Okay, if we are not able to manage by this, and as you said, there was a perforation in this case, so this patient will require laparotomy as there is a perforation also. And then depending on the findings at the surgery, whether it is just a sealed off perforation which has spread the infection, there is a pus in the peritoneum which needs to be cleared off, there are any adhesions, or if it is very bad sepsis, as I said, even anaerobic sepsis sets in, the patient may require even hysterectomy at this stage. Okay, so that decision need to be taken, but her management will be stabilizing her, taking care of sepsis, IV fluids. She may require inotropes later on, depending on that, higher antibiotics which will take care of gram negative, positive as well as anaerobic, and then depending on her CBC, whether she needs any blood transfusion, whether she is in DIC, that need to be taken care in these patients. And better to put a drain if we have done a laparotomy, because sometimes there can be an injury to the intestine, which can be, so we will have to explore the intestines also, the surrounding organs, even like the bladder, particularly the intestine with history of perforation. Okay. And the lavage we have to give peritoneal, because it can go even sub-diaphragmatic pus collection and all that.
Dr. Geeta, if such patient comes, how will be your approach?
First of all, she has to be stabilized. She has to have her IV fluids going, and she has to have her antibiotic going. But most importantly, since there's a history of perforation, you have no choice except once you stabilized her, you have to open her up. Once you open her up, then you judge how badly it is. If it's torn very badly, if it's a ragged tear, you'll have to do a hysterectomy. I don't think there's any choice in that matter. But I think that's where that's the way of we have to manage this.
So intraoperative findings were there was 200 ml of yellowish dirty collection, no bowel perforation seen. There was broad ligament hematoma on right side of 5 by 4 centimeter. Uterus color contour was intact and bilateral tubes, ovaries were healthy. Hematoma was drained, peritoneal lavage was given, and intraperitoneal drain was kept, and patient was shifted to ICU. So this way, the septic abortion, which we normally say are illegal abortions only, but sometimes they are iatrogenic abortions also. Iatrogenically, some harm is done to the patient and the patient lands up in sepsis.
That's what, one thing I would like to add here is, now when they come to us with sepsis, and we still find detect process of conception, yes, we are going to do evacuation of the uterus. And one has to be very careful, because the uterus is so soft due to sepsis, and the products are adherent. The moment you touch, the patient can bleed torrentially. Okay. So one has to be very careful. One of the patient who had taken medical abortion pill outside for 12 weeks, bleeding for 1 month, and then she had anemia also. We gave her antibiotic. We started on blood. We took her. She bled so much, on table, that I had to do tamponade for balloon tamponade. I used Foley's catheter because it was 12 weeks, shifted her to HDU, gave her massive blood transfusion, and I have not seen, she was bleeding like a tap. So one has to also take into consideration that they can bleed profusely even during evacuation of the uterus, and uterus is not responsive to oxytocin once there is a sepsis. It will not contract and retract. Okay, it will be, you will find that oxytocin does not work in these patients.
One thing to add here, that if you find such kind of cases, emergency ultrasonography and an X-ray would give you quite a good idea of how bad your things are, and you can detect certain things. For sure, laparotomy would be needed in these cases, and these are typical cases where higher antibiotics have to be used, because you can't wait for giving a lower antibiotic and then waiting, because it's question of their life. So these are the real indication where tazobactam, piperacillin, imipenems, which do not affect your renal function, because in these cases it's very, very common to have acute renal injuries. So those kind of antibiotics should be used here. As per CDC regime, we are giving cephalosporins, we are giving gram-negative cover and anaerobic, which is metronidazole. So we can do that, but gram-negative generally are gentamicins and clindamycins. So you have to be very, very cautious while giving that.
Very true. So what are indications of surgery in case of septic abortion? If there is injury to uterus, suspected bowel injury, presence of foreign body in uterus, in abdomen, unresponsive peritonitis, suggestive of collection of pus, and septic shock not responding. Just a few days back, one of my colleagues shared with me, she had similar patient who had come. Patient was taken by her husband to a surgeon. Okay, and surgeon got her MTP done, surgical evacuation done. They have come with acute pain in abdomen. So she was examined, and it was found in PS examination there was a rent in the anterior fornix. So a rent was made in anterior fornix, and what evacuation they have done, I don't know. And then this, my friend, she evacuated the conceptus, and then the things were done. So the things happen. You have to be very vigilant and should reach to a proper person to get proper thing done. So principle of management of septic shock are as told by Dr. Geeta: appropriate supportive care, correction of hemodynamics, broad spectrum antibiotics, correction of acidosis, removal of source of sepsis. So tragedy of septic induced abortion is totally preventable. Prevention by providing effective contraception and safe abortion, antenatal care and institutional deliveries, bring down C-section rate. This is again important because it increases more and more of sepsis and more of adherent products, and medical abortions generally fail. What I have observed is patients with previous C-section have more failure in medical abortion because some products are adherent to their previous scar. So prompt diagnosis at any of any septic complication and their effective treatment at tertiary care hospitals would provide such serious consequences. Which antibiotic? A word about antibiotic I would like to know by all the three speakers. What
So, I would say definitely a cephalosporin, maybe a first or second or a third generation, along with clindamycin for your gram negatives and a metronidazole for your anaerobes. This combination would probably work when you're starting empirical treatment and you're waiting for your cultures to come back. So that would be your empirical treatment. Unless, of course, she is in shock. And then, as Poonam said, you'd have to probably start on extended spectrum penicillin, like piperacillin, tazobactam. Yeah. But, you know, the problem with imipenems is that carbapenems is that it's being used even for a 1 day and 2 day old baby. So we are going to get resistance to that also very quickly. So, and we
are using it outrightly. The way they are being used, I'm telling you, there'll be a time when we are going to have
resistant to all.
But you know that we don't have any antibiotics right now. There are no new molecules which are being produced, and people should understand that. They may keep on changing imipenem to meropenem or something or the other, but we have no
that
new.
Is why no, even urine culture report, when you see, you find now they are sensitive to only those higher antibiotics. You know, you don't have anything to prescribe there. All resistant. You know.
But Sheila, that's our fault. We as doctors,
definitely.
The world,
because every fever is treated with antibiotics.
Exactly.
Patient need not come to you. The patient buys across the counter. You know, 2 days, 1 day antibiotic they take, they're fine. They stop it.
Yeah, but normal vaginal delivery, how many people are giving antibiotics for normal vaginal delivery? That's a shame. They should not be getting a single antibiotic.
To start with the normal antibiotics, where there's no word normal, but then the one which we are using regularly. But do not start immediately with the meropenem. Maybe
have you see? We are not able to get ampicillin nowadays. Even if you want to prescribe.
Cefazolin went out off the market in Chennai for a while. I don't know if it's back now, but that was a drug that we were using constantly. So anyway, go ahead.
So now this is our next case. Her primary, 37 weeks, underwent elective C-section for breech and was discharged on day 3. Everything was uneventful. Patient only had history of 3 episodes of UTI antenatally, which were E. coli. This patient came back on 5th day, post-operative day. She had fever, so she took paracetamol on her own, and she was brought on day 7 with history of fever, nausea, vomiting, and pain in abdomen. And her abdomen patient uterus was well contracted, but it was tender. Bleeding PV was average. Her lab said total counts of 18,000. Urine culture showed 100 to 200 pus cells, and patient was put on higher antibiotics.
What are higher antibiotics, Pragati? May I know? What are higher antibiotics? Do you have any idea what they started her on? Because I don't believe there are any.
And was she treated antenatally? She had 3 episodes of UTI.
She received norfloxacin on her first UTI, and then she had no follow-up, but then she has reported 3 UTIs. She has come to antenatal care for her urinary complaints. Okay. And she has received 1 course of nitrofurantoin. That's all. And now this time she was admitted with fever and chills on the 5th post-op day.
Okay.
So, and this patient showed deterioration and her saturation was dropping down, and she was shifted to ICU, and she required anotropes, non-invasive ventilation, and rigorous and IV fluid management was given to her. So why is a pregnant patient more prone to UTIs and how to treat those UTIs?
See, in pregnant patients, what happens physiologically also there are changes, you know. All of us, we know. First of all, the urethra is short. Then if she already has some predisposing infections which can be associated with UTI also, okay. And another thing, like if she has gonorrhea or she has chlamydia also can give rise to UTI associated. And then the changes in the urinary system during pregnancy, we know there is dilatation and sometimes there is a reflux from the bladder to the ureter. So chances of ascending infection are also very high. So whenever the patient comes with symptom, yes, we should ask. And asymptomatic bacteriuria is again a very common thing. So we have to rule out that. Now in asymptomatic bacteriuria, what we say, the count of 1 lakh, you know. But even if sometimes the count is not so high, it is some 20,000 or 50,000 also, but this patient will still require antibiotics and should be taken into consideration. Because if it is not treated, can lead to pyelonephritis and can lead to severe sepsis, like how this patient has prevented. Now this was post-cesarean, okay. So as we said that aseptic precautions, even one catheterization also can give rise to infection, you know, if it is not done properly. So that also matters a lot. So we have to see that even though like sometimes we are consultants, we don't do the catheterization. Catheterization is done by somebody else and we are just there to pay. But you know, I think it is very important, and I still remember my madam, you know, when I was doing, she was so important about catheterization that it has to be a proper tray, proper precautions, aseptic precautions are taken and then the catheter is put in. So that way. And then the antenatal patient is treated with, now nitrofurantoin is our first choice, okay. Now sometimes if the patient is still symptomatic, we can still extend the dose from BD to OD and continue that and repeatedly follow the patients. That need to be done, as she already had 3 episodes of antenatal urinary tract infection, okay, and E. coli. So I think that precaution need to be taken, and now she has come with full-blown sepsis, I think. So there are many things which can contribute to it, whether it is only urinary tract infection which is contributing, or she has undergone a cesarean section also. So maybe it is
was again done.
Yeah.
She had a history of UTIs and again catheterization was done for a C-section.
Yeah.
So again a positive.
And then recurrence can also happen during pregnancy. So we have to see to it that they are always treated properly. Now the antibiotics, as I said, nitrofurantoin is the first choice. Then we have amoxiclav, which also can be given. And when it is severe, we would like to give IV antibiotics whenever there is a patient comes with fever and chills. In that case, it is better 24 to 48 hours we treat her with IV. And then we switch on to oral. Okay, but here it is a full-blown sepsis. So according to that, we will have to give her third generation cephalosporins. Then we may have to also give her quinolones because it is a urinary tract infection. And then for anaerobic infection also, we will have to add metronidazole. Then this patient may require meropenem and all those because they are better for urinary tract infections. Meanwhile, if the culture report comes, it will be good.
So, madam, how long do you treat a patient with, like how you follow a patient who had UTI in pregnancy? How long antibiotics should be given? What follow-up advice we should give her? When should she get her urine test done again to prevent these complications in future?
So any woman who's had a urinary tract infection must have, first of all, if it's just a very mild dysuria, her culture came back with E. coli sensitive to most antibiotics, it's not an issue. But if she gets a second UTI in the same pregnancy, I would then, after the treatment is over, I would repeat a culture again. And at that point, I would not just wait for it to be 100,000 colonies. I would say even if 30,000 or 40,000 or 50,000 is still significant, then I would change an antibiotic and make sure that she gets cured of it completely. Because we know that once you get pyelonephritis in pregnancy, because of the progesterone causing dilatation of the ureters, the ascending infection can be quite significant. And we know that 20% of pyelonephritis, patients with pyelonephritis will go into sepsis. So these women will have to be admitted if once they get pyelonephritis. If once you treat a patient for pyelonephritis, hospitalized her, given her IV antibiotics, got her completely cured, I would continue her till delivery. That not just me. I'm sorry, I shouldn't say that. Evidence shows that the recommendations are that we should continue some sort of suppressive therapy up to term. Up to term, we should be giving her 1 tablet of nitrofurantoin a day till she delivers, because so that she doesn't get a recurrence. In this case, if she had had that, she may not have had this post.
With 3 episodes. Yeah.
She required a good prophylaxis for that case.
So, do we really do a urine culture as a part of her routine investigations, or do we not?
Are you talking about asymptomatic bacteriuria?
Yeah.
Okay, so that's a question I would like to ask everybody, because we never checked for asymptomatic bacteriuria, and WHO still says that in developing countries, it's not a possibility for everybody to go and get a urine culture. It's expensive. So to get that done, they are saying just do on the spot gram-negative stain of the urine, if that's possible.
They do some dipstick test, right?
Or if you have a dipstick, that's also, but WHO says not even a dipstick, because that's also expensive. So you may not have access to that.
Ma'am, I think that we are routinely doing proteins, sugars and microscopy. In that, if we get lot of pus cells, that should be the time when we should go for urine culture sensitivity. But as a routine, adding it as a routine investigation would not be so.
I think if the number of bacteria, they say up to 200 or something, then we should be. I mean, advising.
Again, we are now for albumin and sugar, you're only using dipsticks, most of the places. If you're looking through the microscope for doing a urine routine, that's different. If you see pus cells, no question about it. If she's symptomatic, that's different. But asymptomatic bacteriuria, I'm not sure how many of us are doing it. I certainly did not do it. It is a recommendation by Western guidelines. Yeah, no doubt about it. 100%. But then they have the money. They are allowed, they are going to be paid for by some insurance company. But in our country, I would say that we have to be very...
We are doing routinely hepatitis B, C. So
C also. Yeah.
So much. So that's
hepatitis B we do.
So even doing thyroid, TSH is routinely being done. So should we add or should we not add? I mean, it's just a matter.
Recommendations are that it should be added. And I think a lot of obstetricians in the urban areas have started adding it. At least, if not, that's not done, at least a nitrite stick, I think, dipstick should be done. I think maybe that should be just to avoid these cases of pyelonephritis.
And Pragati, this is very important that everyone should be taught how to do catheterization. The way you should scrub, the way you should hold the Foley's catheter. I have seen, people putting the catheter in the vagina and then taking out and immediately putting it in the... That's really something you are doing. You are giving them infection. So one has to be serious about it.
That's what I said.
That is true. So
how long do you keep it? How long do you keep it? There are institutions, I'm sure ma'am would say that you do catheterization, do the cesarean section and
remove it.
Remove it. You don't have to keep it for 24 hours, 48 hours, 72 hours unless indicated.
No, we do DC after 12 hours. By evening, morning, if we have done the section, by evening we remove the catheter.
So that also reduces quite a bit of UTI and, persistent UTI.
Yeah. And I think every senior doctor, however senior you are, you have to make sure, because I always work with the team, though mine was a small hospital, 30-bedded hospital. We were doing up to 100 deliveries a month. We always worked with a team. I always had residents and registrars and junior consultants. Anybody who joined the hospital was taught two things. One was how to tie a double-handed knot, and secondly, and a square knot. And secondly was how to catheterize. And of course, how to scrub. People who had done MDs and came in.
Very interesting skill lab, those mannequins are there nowadays, to teach that. So,
but still, mannequin won't get UTI. Our pregnant women will. So we have to teach them, make sure that they'll do it beautifully on a mannequin. They have to make sure they don't do this. You know, putting it in the vagina and having to throw that catheter away, it's expensive, right? So you have to make sure that if they happen to do it, it's fine. Throw it away. Let's start with a new catheter.
That is this to be told. Right. You know, so we can say when a patient who has pus cells in a routine urine sample, we can send her for culture. Nice guidelines say to do urine cultures for every ANC patient at 12 to 16 weeks. So in our country with low resource setting, at least of urine positive for pus cells, we can ask them to get a culture done. And you know, how is your experience about this new molecule phosphomycin which has come? Single drug, single dose.
It's being discussed quite a bit, and there are some research papers which have come up. But yet, you know, the place where I'm working, the cost of it is so much
very expensive.
Routinely giving it to the patients is still a question to all of us. And there are some research papers which I saw very recently. They talked about some side effects and all that. So I think we need to weigh pros and cons and see how good it is. And
so Pragati, when it comes to pregnant women, let's go stick to molecules that have been there for 2 or 3 decades, okay? And then switch to anything new. 1, phosphomycin is very expensive. 2, it's been on the market for a very recent amount of time. And I don't want to try that.
At least we are not using it during pregnancy. As we said, whatever we are using for 2-3 decades, we follow the same.
Exactly. When it comes to obstetrics, I think we have to stick to the tried and tested, because you might find out 2 years from now that these babies have some cognitive defect. We don't know. I mean, phosphomycin may be a fantastic molecule and we may all start using it consistently. But at this point, I think anything new, be a little careful. Watch out for your patient.
And, you know, in hysterectomy, to avoid hysterectomy, you know, for fibroids, uripristal was day in and day out used. And then 2 years after, they realized that all these women are coming back with liver issues. So I think we really need to look into it.
Liver transplant has been, I think some patients have undergone liver transplant.
I mean, we have to look into the randomized controlled trials which have been done.
100%. You are speaking my language, Poonam. I am all for RCTs and all guidelines. See, we can't all do clinical studies. We don't have the facilities. But please follow guidelines, and there everywhere. Yeah.
So now this is a patient, 27 years, gravida 2 paravan, 36 weeks with fever, breathlessness since 2 days. Her X-ray showed lower zone consolidation and USG showed single live intrauterine pregnancy of 34 weeks with IUGR and moderate oligohydramnios. On examination, she was tachypnic. Her saturation was 92, heart rate was 106, blood pressure was 110/70. With she came on bag mask oxygenation of 4 liters per minute. Total counts were raised, 22,000. CRP was raised. She was put on antibiotics and steroids and positive pressure of ventilation. So, what will be obstetric management in this patient who has come with acute respiratory distress?
So, basically, I want to know what antibiotics can be started on somebody who is possibly pneumonia, isn't it?
Yes,
sounds like pneumonia. If she had fever and she's breathless, it could be most probably viral, isn't it? Why are we starting her on broad spectrum antibiotics without knowing? So now you're showing H1N1. So why was she on broad spectrum antibiotics?
May not be knowing, no, when the patient comes with consolidation and signs of pneumonia. I think till the report. Must be awaiting.
Viral pneumonias are many times superimposed with some
bacterial infection also. And which is what is happening with COVID also now, you know.
Secondary bacterial infection prevention to give higher antibiotics.
Yeah, the choice of antibiotic, antiviral is must in these patients, you know. We have to start them on antiviral. There is no question once we know that. And we know that there is vertical transmission also is happening in these cases, even in H1N1. So we have to start them on that is the same oseltamivir 75 milligram BD.
So this patient was a non-invasive ventilator and her throat swab came positive for H1N1. She was immediately started on oseltamivir 75 milligrams BD, and in spite of non-invasive, she was hypoxic, tachypnic and acidotic, accessoristive or acute ARDS. Patient was not improving, so was intubated and was put on ventilator as the days advanced. She was worsening and she required ventilatory support for long time. So tracheostomy was done on day 7 and she developed barotrauma and emphysema also, and day 14 she required inotropic support. Day 15 persistent hypertension, and despite inotropics she went into acute renal failure and succumbed.
I think that's what happened in 2009. It started in April, you know.
Yeah.
Now definitely I think it's not, the virulence has come down, but when we first experienced it in 2009, I think the mortality was very high during pregnancy. So we know that there was a virulence and the patients, the mortality was really high at that time. But now I don't think, and now I think prophylaxis, we look at prophylaxis also. We are vaccinating them during pregnancy. Again, Dr. Poonam, we know that it's government level, it is not possible again to vaccinate them, but in private, Dr. Geeta, definitely we do vaccinate them now. What is your experience?
So, Sheila, one of the most important things is that, as you said, most of our data is from the 2009 pandemic, and the mortality rate in the third trimester was as high as 80%. And there was a slight difference between, like in the papers, which from Rajasthan was 70%, South India was 55% mortality, tertiary care in South India was about 25%. So it depends on how much effort, treatment they got. But the thing is, there is no two ways about it. Every woman who comes to you antenatally must be given H1N1, I mean a flu vaccine, flu shot, and it should be given. Don't worry about first trimester, second trimester, third trimester. It must be given. And the quadriflu, which is the quadrivalent, which has both influenza A, H1N1, H2N3, and influenza B, should be given. And I think if the government is going to look at it, they should bring this in, because you can't afford women to die of this. If they can bring in TT, which is much cheaper, I know, Tdap, TT. This should be a part of every woman's antenatal care. There is no...
Actually, now there is a TD at government places, public sector, it is TD. In private, we are giving Tdap. No, Poonam? It is TD now, which is available.
Government sector, TD.
TD is available.
TD is fine,
No more TT now.
No more TT, and it's not available also now,
Right. It's TD and Tdap in private.
But influenza vaccine have to be given every year as the strain keeps on changing. So again, it's a very expensive, and to repeat it annually is really very difficult for us.
But at least a pregnant woman, it is must.
Should receive it.
But for a pregnancy,
unless she's getting pregnant annually, it's fine. Once she gets it during her pregnancy, at least she won't die. You won't die of H1N1.
No, but earlier we used to say give it at 24 weeks. But as you are saying, give it as soon as she is pregnant is better?
Absolutely. There is no question about number of weeks. They have clearly the recommendations, the guidelines are, the minute the woman comes to you and she's pregnant, you give her H1N1. It just doesn't matter if she's first trimester.
Even first trimester? Because
Yes, positively. I have done a lot of reading on this, because we made this part of the recommendations.
Which are the vaccines which we can give? One is influenza. Hepatitis B also can be given in pregnancy.
Hepatitis B vaccine.
That you can give it in pregnancy.
Yes. Other than rubella, which is a live vaccine.
Live vaccine.
Yeah. And even rubella, if you do give it, it doesn't mean that the patient...
Termination is not required,
Yeah, right.
So oseltamivir, the dose have been...
otherwise the inhalation,
Inhalation dose also available, but in pregnancy, oseltamivir is safe, we can give it.
We heard so much now, I think all patients with mild symptoms are receiving this drug now.
And this corona has also taken us to those viral infections and...
they are receiving, all mild patients, mild cases receive this only.
Right.
So even as with H1N1, we also should suspect whenever patient come with fever, like dengue fever. When you suspect and how you diagnose?
I think you have to...
Again, investigation, and you look for antibodies, I mean the IgM, IgG, and that is how you diagnose it, if you have a suspicion, and all associated investigations, as we know that dengue, platelets starts dropping, so we will have to get again a coagulation profile done, and we have to look at the platelets, because it's very important to have, because she's for vaginal delivery or cesarean.
Daily CBC gives us a good information. Platelets are dropping and hematocrit rises. So this is again a very important.
I think the fact that you have to be a little aware of the seasonal variation in your area, because we definitely in Chennai we have a seasonality to dengue. So the moment you start having that upsurge of dengue fever, then if your patient comes in with that and it's lasting for more than 2 to 3 days, then you just simple thing as a platelet count. And if it's low, then you have to start. But remember that a platelet count can drop even in a regular viral infection. It doesn't have to be just dengue.
One more thing is, even if the platelet count is normal and she is a patient of dengue, they are destructive platelets. The patient, if we take her for cesarean, she can still have bleeding, she can have hematomas in the wound. So we have to be very careful with these patients with a normal platelet count or okay platelet count also. It is better to put a drain, in the wound, because sometimes there may be hematoma, there may be bleeding, So it is better to put a drain, subcuticular drain, because sometimes there may be bleeding in these patients.
Okay. And in lab diagnosis, rapid NS1 test is done, which detects if there is fever of 3 days, and dengue, IgG, IgM are done if fever of more than 5 days. Baseline CBC is very useful, and many times we have to be very alert, because it sometimes give us a patient with PIH with a HELP syndrome, and DD, it's always a differential diagnosis for dengue fever, and we have to treat it once it's diagnosed. These are all treatment of dengue fever. Avoid induction of flavor, planned surgery in this active phase when patient is having warning signs in fever patient with dengue. So our next case is case of PROM. She's second gravida, parabon, 16 weeks with history of watery discharge since 6 hours. She was examined on a PV examination. There was a frank PPROM. Total counts were raised. USG was suggestive of 16 weeks pregnancy with oligohydramnios, and she was started with tablet erythromycin and was shifted to higher center. This was a patient from a small village, and she was asked to go to a higher center for with this PPROM. But this patient reached after 3rd day at night with fever, rigors, headache, low abdominal pain, nausea. And on examination, she was tachypneic, hypertension was there, and she was started on amoxiclav. So how will we deal with these patients with PPROM, 16 weeks?
So as per the guidelines, if you are having PPROM at less than 28 weeks, then, one would not really like to. You can give antibiotic for a while so that the infection settles down a bit, but then you would like to terminate the pregnancy, because it is not possible with that kind of infection. You will later cause endometritis and all for the patient. So these are the patients who have to be terminated. But then the treatment becomes very different when it comes on to early PPROM and late PPROM. Then you have to salvage the baby, and then for this particular case, you would definitely do all investigations. You would do all the let's not talk about that, because first to confirm whether it is truly PPROM, you do those tests and all. But then this pregnancy will not be continued.
Absolutely.
How you terminate this pregnancy with PPROM? So your choice, huh?
The question here is that most of the people, they try oral mesoprost and all, but here fever is something which you have to be very careful about, because prostaglandins higher doses also cause fever. So one has to be very careful while.
I think, Poonam, we can use mifepristone, 200 mg TID for 2 days. Even that can also help for termination of pregnancy, because RCOG, even for IUD, they recommend that. So in spite of that, we can use mifepristone.
200 mg TID
for 2 days. Yeah.
Okay. So she was investigated and her CRP was raised 47 milligram per ml. Serum lactate was 2.2 at that day, and at per speculum examination, they could feel POCs and augmented with misoprostol. On day 4, fever continued. She had hypertension. Patient was deteriorating, and her serum lactate raised to 12 millimoles. Platelets were dipped to 17,000, and this was a full-blown septic shock. And the saturation fall to 84%. Blood pressure also 80/50. So fever and pain continued. Patient was shifted. She was put on injection tazobactam, 4.5 gram 8 hourly, and IV metrogen. 5th day, her coagulation profile also deranged. She had bleeding PV continuously. DIC had set in. She was given FFPs and platelets, and then evacuation was scheduled. Pulse measuring POCs at OS were removed manually, and cavity was emptied by suction. Patient was intubated and ventilated. She required inotropic support as her condition deteriorated, and her culture reports, which were sent on the first day, came E. coli, and 6th day she developed bradycardia, asystolia, and she could not be revived in spite of this. So
she was into irreversible stage. She was into irreversible stage already.
But there was time in hand. So what went wrong in this patient? How could
this was really a mismanaged case, I would say, because you see, she had PPROM at 16 weeks, where for these many days, patient should have
3 days
continued. Number 1, you give antibiotic, wait for 24 hours, and then you have to evacuate. You have to ensure that the evacuation is done. And if you keep pulling her like this, then obviously she's going to go into sepsis and septic shock.
Right, because this is the first of all, I'm not even going to label this PPRO.
PPRO, exactly.
I'm going to just say this is a spontaneous abortion, miscarriage, sorry. Okay, she came in with ruptured membranes at 16 weeks. It was an inevitable abortion. So inevitable miscarriage. So at that point, she should have been evacuated and the story would have ended.
Prompt action, I think.
Yeah, because she's coming with ruptured membranes. She's come in, this is classic inevitable definition of inevitable miscarriage. So once you evacuate her, that would have been the end of the story, because this is not a premature rupture of membranes. This is part of your miscarriage. Secondly, as Poonam rightly said, antibiotic coverage for 24 hours and get those products out, get that baby out. How you do it, and if you can't do it medically, do it surgically. It doesn't matter.
Yeah, it doesn't matter. Yeah, 16 weeks.
Yeah. Get it out. Once you get it, you're saying this is a poor woman who's come from a village. They would have had to sell their house to do all this, whatever, and she's died on top of everything. Okay, so this is, I mean, the amount of money that
I think this reminds us of an Ireland story. No, a dentist.
Dentist.
Yeah.
Similar, same case. Yeah.
Yeah. So this is. I think we have to be careful about this. But if this had been somebody who was, let's say, 30 weeks or 34 weeks, then I think there we have to follow the recommendations are very clear. You give her antibiotics, and WHO also still says oral erythromycin is absolutely fine. 4 times a day, you give it for 10 days, hospitalize her. And then if depending on what's happening, you either keep her or send her home, or you can give IV ampicillin and IV erythromycin. So anything other than augmented. Amoxiclav cannot be given to a woman who
necrotizing enterocolitis,
because you're going to save that baby, and that baby will get necrotizing enterocolitis. So we can't give that. Other than that, there are very specific recommendations, and it doesn't matter what you use in your hospital, but please use the same thing every time so that your entire team knows that a woman comes in with PPROM, this is what we are going to give. You're not going to keep changing the schedule for every different patient. So just choose whichever one. There are 3 or 4, which is fine. You use one of those.
And one important thing about PPROM is that one should not try to be too heroic. You know, saying that, okay, my place patient came at 24 weeks and then I can...
Expectant, I mean, you should know where to stop.
Yeah, expectant management is only in those cases which are tertiary care hospitals, where the monitoring is proper, where the NICU care is there, and PPROM cases generally should be in the tertiary care hospital, when an ICU is there and you can take care of the babies. So don't try to be too heroic. You give steroids, wait for 24, 48 hours, and then after that you must take out the baby, because it's going to cause chorioamnionitis, it can cause placental abruption, it can cause congenital pneumonia to the baby. So many things.
Yeah, thinking that in PPRM, as we know that even though the latent phase is more, but you will have to monitor the patient for other, infection and everything. Yeah. There is no point in pulling on, and we have seen
ART pregnancies nowadays, they are coming up with these kind of issues like PROM, and they are the cases where
immunosuppressed already.
They are all looking for the baby. So in those cases, let them be in the tertiary care hospital, let them be monitored well, and but don't try, I have seen people came with PROM and they were sent back home. 5 days after, when they came back, they were really bad.
Sepsis.
So absolutely do not keep them or send them back home or do something.
Take them up to the time, the birth. See, all of you know which one, at what stage you can save the baby. Can you save them at 28 weeks or 32 weeks or 34 weeks, right? So depending on what facilities you have, you try to take that patient up to that level. If you can save them at 30 weeks, your NICU is that good, that's fine. Deliver at 30 weeks.
Yeah, but you should know your threshold.
Yeah, but otherwise 34 weeks. Pragati, before we go on to anything else, since you brought in that H1N1, I just thought quickly, because there are a lot of questions about COVID-19 and what it's doing to mothers. So since we've talked about that viral, can I just quickly talk about...
Yes, ma'am. Yeah, bilkul, yeah, yes.
So I was going, because these are questions that lay people are asking us and doctors are being questioned about this. So as of now, the data is very, very limited. But whatever we know that mothers are not doing badly in with the COVID infection. That's one. Secondly, babies, we don't know yet, because we don't know what the long-term effects are going to be. Because if COVID can mess up an adult's lungs and cause long-term effects on the lungs, we don't know what it's going to do to a fetus. But as of now, we don't have any data that it's damaging the baby. We'll have to wait for that. Thirdly, the third question, and because though I've retired, I keep getting people calling me up. Can I get pregnant now because I have nothing else to do? I'm working from home. Can I get pregnant now? I'm like, please don't, because we don't have the data yet. So we don't know what it's going to do to your baby, what it's going to do to you. So please postpone at least for 6 months or a year. And then, if you get pregnant, I'm not going to suggest a termination.
I have a patient with anencephaly. She's positive. She is 23 weeks. Now such a dilemma whether to go ahead and abort or whether to wait till she becomes negative. And she's a previous section, and the baby is just 1 year, 2 months. So I said she may require surgical, and she's positive. So why not to wait for some time and then deliver her? Anyway, it is anencephaly.
Even you can do a hysterotomy.
Yeah, we can do hysterotomy. So it is better to wait till she becomes negative and then do it. That's what we thought. So this case we had day before yesterday. So we have convinced her and we have told her.
23 weeks with anencephaly, Sheila. She didn't have any tests at all, is it? Or because of COVID, a lot of people are
Yes. Because of COVID, no anomaly scan is done in time, and maybe. And people don't have money now, there is so much of crunch. Economy, financially also.
Very true, very true.
Yeah, even we find people also coming to government hospital now for investigations because they can't afford now.
Sure.
For investigations they are coming, they come to government, and we are getting so many unbooked patients now because economy. Okay, so they want to come to government hospitals now and get it done.
Ma'am, one submission is that as we are talking about COVID-19, what we did at our place was that exactly at the door we have created a triage. So all of us must do that. What are the government guidelines?
Yes.
That triaging is very important, and the person who's doing triaging should be, well
trained. Very important.
The catch is there nowadays.
Yes.
And it's always better to have prevention than, having COVID patients and then getting infected and then making your faculty prone for all that stuff. So it's very important that we do a triaging, we decide on non-COVID area, we decide on isolation where you're waiting to see, and we decide on COVID area. There is something, which is very important, because you see, having a labor room separately, having an OT separately where we do not have so much of human resource, it would be wiser to think in terms of having a hybrid labor room and OT, where sometimes, the women who's delivering suddenly ends up in fetal distress, and that same thing can be converted into OT. So those things are, being debated in government also. Because
very true, Poonam, because it is so difficult because there is no manpower.
There's no
in our institution, so many are quarantined because they have turned positive.
Yes.
Because earlier they were managing isolation cases where most of them turn out positive after delivery and after surgery.
Absolutely.
Where people are already exposed.
And you have this much human resource, which now you have to divide into COVID also, isolation also, this also. So you have to plan the strategy and look into the minimal.
Very true. Very true. So I think what you are saying, that hybrid labor room is a very good idea, because we cannot post one group of staff to labor room and another group of staff to OT. So that's what I told my OT nurses. See, you have to manage labor as well as OT.
And BMW, madam, itself is such an issue, maintaining at two places BMW, infection prevention practices, having human resource. You don't have so many anesthesiologists also, that one is at the major OT at COVID hospital and one comes to your. So those things have to be really looked into.
We are having a tough time. But anyway, now one of the hospital is converted into COVID hospital only. One of the major obstetric place. That is the Gosha hospital, we call it as, which is attached to Boring hospital. And another Vani Vilas has also delivered more than 200 now. Where I am working, we have a separate OT. As you said, it is like that hybrid, where we have kept the OT as well as a labor room, so that, we can manage them. The problem with that is, if the patient is in labor, the person has to sit there for a long time. And you don't have that many staff members. Okay. One postgraduate, she is wearing a PPE, and how long can she sit? Yes, even though the threshold is less. Okay. But still it is so difficult, to sit with them and monitor them. It's becoming really difficult.
I think these are good lessons that we have learned. I think Pragati is now waiting to give us the key points of the presentation.
Very wonderful discussion. Any take-home messages from all esteemed panelists regarding the sepsis? I will just note down and I will give you a final.
Just one thing, please follow infection prevention practices.
Very important.
Please look into your BMW that it is not mixed up. Ensure that catheterization should not be taken so lightly. Please ensure that you keep antibiotics for your future generation.
That's very important for future generation. Yes, sir.
I think as we say that sepsis is a neglected thing, when we look at the emergency obstetric care, like PPH, eclampsia, but sepsis also contributes almost so much to maternal mortality as well as morbidity. And when we look at the fatality rate, which is more in India, and we have 20 near-miss cases for one mortality. And that talks about the quality of what health we are providing. So it is very important, as Poonam said, yes, all the precautions and all the protocols to be followed strictly, and the regular visits to the postnatal patients as well as the post-cesarean and the cases, and clinical examination should be paid given a more importance to that, which was beautifully explained by Dr. Geeta. Yes. As I always feel that sepsis is really a neglected thing, starting from catheterization as well as painting. And when the patient is in labor, minimum per vaginal examinations, unnecessary examinations to be avoided to reduce the infection. So there has to be a protocol, and which is followed. A protocol for antibiotics, protocol for examination, protocol for hand wash, everything is there, but it has to be followed. So as we talk about Laksha, what you also know, Poonam, that we are conducting OSCE regularly. And we have really found that by doing this OSCE, we really find that it has really helped to improve many things amongst the staff nurses, and they are also very happy. And I must tell you, that everybody is really working hard towards it in our institution.
Along with us, our staff should be trained. Dr. Geeta?
Very important.
My final messages are, there are two things. One, fever, there should not be a knee-jerk reaction to antibiotics. Okay. And I strongly suggest that all of us start.
It's 5 o'clock.
We all start using the word appropriate antibiotics instead of lower or higher antibiotics. Because there is something known as appropriate antibiotics for that particular
antibiotic stewardness, yeah.
And then the third thing is that all infection prevention comes from the top. So the person who's running the institution or is the head of the department or is the senior most, unless they follow it, you can't say send the junior most person to catheterize unless you have personally trained that junior most person, or at least the rungs going down to the junior most person. And everyone in your staff from the top to the bottom should buy into this philosophy that we are going to follow certain protocols and procedures in the hospital without breaking anything. And we have
6 clean, 6 clean, no, Poonam? We have that 6 clean put up now on the charts.
We can have all these names and
but to be followed.
Slogans, but we have to make sure that they are followed. Okay.
And last thing, Pragati, since we are talking about M&M, I have a recommendation to you, if you can recommend in the Foxy as well. See, we are doing MDR review, what the MDSR is being done. But we are never doing M&M reviews yet. You see, we keep on talking about
death. Very true.
But we are not talking about M&M. M&M gives us so much
very important insights.
And it tells
But I think, Poonam, I remember attending one orientation program where Dr. Padmanabhan did it in Bangalore. For us from Karnataka, where the WHO protocol of M&M and to keep. But I think now again in Laksha, we are supposed to maintain the registry. We are doing the audit.
Registers, ma'am. But what happens is when
audit is happening. We are doing the audit and debriefing.
When reviews are happening, they should also talk about M&M reviews.
Yeah. I think it should be reviewed again. I think debriefing. What I do is, to be very frank now, all near miss cases, mortality, definitely there is a lot of things happening around and it will be quite serious. But for near miss also, debriefing, because what went right and what went wrong.
What went wrong should be done, and we should learn from that, and we should not be again. So it will help in forming the guidelines as well, and that will help in improving and preventing more mortalities.
Yes, Pragati, and see, civil surgeon is already doing MDR meetings, no? So why can't they club the M&M as well? So what will happen, that you will get more ideas, good practices, women is alive, you will get...
That will improve the quality.
Convey this message to Foxy, ki let this be incorporated in that program. I'll just try and talk to her. So it was really wonderful session of near miss on sepsis, and we got a lot of insights. We have learned so many things. All the panelists were real up to mark, and really we got so simple and so important messages. And now I will request our chairpersons to have a word. Dr. Lakshmi, Dr. Kanti.
Thank you, Dr. Pragati.
Yeah.
I think all our delegates, all of us, in fact, after this wonderful, discussion, our maternal mortality rate will definitely go down at least by some percentage. I'm sure about it, because we've learned a lot of tricks and tips. Some more things regarding sepsis. I think it really has very high mortality rate, and it's around 20%. And as one of the panelists, Dr. Sheila Mane, she told that serum lactate, if it is more than 4 nmol, then it's better to give IV 200 ml per kg crystalloids. And also this septic shock, we should think that it's a medical emergency, and so ICU admission and third generation antibiotics is indicated. Then when come on to the first case, conservative management of hepatitis, which is done very timely, that will save many patients. And also we have, sometimes we have to say no to so many things. So we need to withhold exploration at sometimes. And very interestingly, I think Dr. Pragati said about the tetracycline dressing. Maybe it helps in some patients. And regarding guidelines, the 4 P's, that's what I have noted down. So protect liver, first one, and then prevention of encephalopathy, prevention of DIC, and prevention of hepatorenal syndrome. Now coming to case 3, septic abortion. Be very careful when you're going to attempt for DNC, because again, one of the panelists said it's so soft during sepsis, the uterus, so they bleed a lot during that time. And this is, and uterus is also not responsive to oxytocins and all. It is totally preventable. And and I think again, one of the panelists of Pragati said that bring down the CS section rates. So that will again prevent. So what we have also learned is prevention. Coming to the urosepsis, it's urine, it's like the change, why there is urinary changes in pregnant lady that causes, and also asymptomatic bacteria that can also lead to pyelonephritis, and we need to be very careful. Nitrofurantoin 50 to 100 milligrams 4 times a day, and augmentin
twice a day.
Yeah, correct. So prevention of acute pyelonephritis in pregnancy can be done. We should be getting the urine culture sensitivity at around 12 to 16 weeks. And asymptomatic UTI also can lead to pyelonephritis. I already told you all. Now coming to the case 5, ARDS. So antiviral is a must in these cases. Vaccinate. We can vaccinate in all trimesters, but I think Dr. Geeta Arjun told very well. Vaccinate the day she is pregnant. If she comes to you, whenever, the first time, so that she is protected for the whole of her pregnancy. And you have to also suspect dengue fever and treat accordingly. And PROM, questions. You have to know whether the fever is due to prostaglandins or it is due to some other infection, which is fever.
On Zoom chat.
And removal of POC is very important. Antibiotics, removal of POC either surgically or manually is important. Now coming to COVID-19, we have to always have in mind in this era, and as an infertility specialist, I think Lakshmi will also agree with me. What I have done is I counsel my patients not to undergo IVF now. Let them wait till we get a vaccine or something. It's not far away. We have to be very positive for these patients. And it's better to really postpone the pregnancy. But in case a patient comes with pregnancy, it's a very immunosuppressive period, the whole pregnancy. So we need to counsel. Even for antenatal care, we may tell them to come as less as possible, and also telemedicine must be used now. And the rest of the things the panelists have told so well, and Pragati, congratulations, all Dr. Sheila, Dr. Geeta, Dr. Poonam, congratulations to you all. Lakshmi, wonderful, always with you. I enjoy every session with you. Thank you.
Thank you. Thank you.
My job was made easier by Dr. Kanti Bansal. She has already summarized and gave expert comments on all the 5 cases. I must say, Pragati, you conducted it very well. It was very informative panel discussion. I just want to say that whenever you have a near miss case in your setup, at least have internal audit and internal meetings. Meetings not to blame the staff, but just to find out what you can do to improve the situation in your setup, and the staff who has helped you in averting the tragedy should be given some incentive, and this incentive always need not be a financial incentive. If you just appreciate that staff in front of everyone, I think that goes a long way in keeping the motivation of your staff. They would definitely try to avoid the tragedies and mishaps in your hospital, because ultimately it's a teamwork. You alone can't do anything for the patient, right from the catheterization, painting, draping. I mean, you have to depend on your staff. So it is best to maintain their morale, give them proper training, and in between, time to time, update their knowledge. And of course, I do believe in giving them incentive. So thank you so much, Pragati, for wonderful moderation, and all the three lovely, eminent experts, Poonam, Geeta, and Sheila, and of course, Kanti, my dear friend.
Say hi to all.
Thank you so much. I thoroughly enjoyed being with you all. Thank you so much.
Same here, Lakshmi, because
She
of
was
your
holding on
presence
since
and
morning, you know.
managing so many webinars together, present fully here and giving us so many inputs, so important input, is really appreciable.
Thank you, Pragati. Thank you so much.
Yeah, so there are a few questions.
See you all. See you.
There are few questions which I take over. So, how to diagnose a case of sepsis, which we have, I think, covered in all discussion. Chorioamnionitis and dental caries. How do we manage? Dental caries in pregnancy. Not audible.
Yeah,
I think this
infections can be associated with sepsis, but not chorioamnionitis. Chorioamnionitis is plainly because of ascending infection from the vagina. It has no connection to that, as far as I know.
So for dental caries, like how you manage?
Yeah,
We
well,
must
but-
ask this question for that dental caries and gastroenteritis. How you treat in pregnancy?
See, dental caries is something which where you give antibiotics and all. So all what you have to know is that when you go and see, you can get the cleaning done. It's not a contraindication, but the antibiotics should be asked to the obstetrician, because there are some antibiotics which they give which are not really good for baby, and then in which trimester you are, one has to look into. So dental caries, having the treatment done where you clean it, and then giving antibiotic, giving anti-inflammatories also, one has to know what is to be given. Otherwise, it's not something which should not be taken care of.
Then, is there any role of steroids in septicemic shock by Dr. Seema Pasricha?
Yes,
Steroid?
there's a definite role, because it is an anti-inflammatory. There, steroids act as an anti-inflammatory, but then you have to weigh the pros and cons, because steroids also make you more prone for infection on one side, but in septicemic shock, they definitely have a role.
Definitely. Injection cefazolin single doses before taking the incision. Dr. Geetarjan, you have been telling in progress. Yeah. Yes, ma'am. Please go ahead with the prophylactic dose of antibiotic for C-section.
Right. So you give 1 gram of cefazolin, or if it's not available, you can use a second generation ceftriaxone you can use, and you give it just before your incision. So you give it intravenously. Our anesthetist used to give it just before the incision. They'll put it in the IV fluid. So if you have it within 20 minutes or 10 minutes or 5 minutes before that, you will have a good tissue level, and then you can go ahead, and that's all we give. And that's worked for hysterectomies also. The only time we repeated a cefazolin injection was if the woman had a ruptured PROM for more than 12 hours. Then we would repeat 1 or 2 more doses. But otherwise, it was just a single dose.
So you have an antibiotic policy in your place.
100%. That's a very important thing.
I think that is important, to have an antibiotic policy.
All hospitals should have an
Have their own antibiotic policy.
Antibiotic committee. So if a doctor in that hospital writes something and that goes to the pharmacy, they cannot release that antibiotic till it goes to the antibiotic committee. And that's what Arjun, my husband who ran Sundara Medical Foundation, he made sure that there was an antibiotic committee and antibiotic policy.
Yeah,
so
microbiologists immediately call us, that why are we prescribing a higher antibiotic? Yeah.
Exactly.
No, yeah, this is for UTI. In moderate to poor setup places, will you take number of pus cells and epithelial cells into account to take a decision of advising urine culture and sensitivity, or straightway advising asymptomatic bacteria?
I think we discussed that. If you don't have the facilities, you can do a urine routine and look for pus cells, but that will not give you bacterial count. So if at all you're going to look specifically for bacteria, WHO is recommending that you do a gram stain. At least do a gram stain and look for bacteria. If there are bacteria present, then you do a urine culture. But for others, you don't have to do it. Those who don't show bacteria, because pus cells will come only when there's an infection. We are talking of an asymptomatic bacteriuria, which means there is bacteria in the urine, but no infection, no cystitis, so therefore no pus cells.
Okay. For PPROM of 24 to 28 weeks, how will we terminate?
I think here, as we said, that the latent phase is slightly more, and as Dr. Poonam already said, that we should not be waiting too much also. So induction, I think we can still go with whatever methods we have, again depends on the Bishop score also. Yeah. But I think 24 to 28 will better respond in my personal experience to misoprostol. Okay, like misoprostol will be a better choice in these patients. To induce labor in these patients, because oxytocin may take a longer time, and if there is a frank leak, sometimes the gel also comes out. So we can use misoprostol either orally or vaginally also.
This question is only out of that. If it's not, it takes long time. That's why she's asked this question. Like we were talking about evacuating. So if it's 24 or 28 weeks, then it's a problem. How to go?
This particular time period, 24 to 28, see viability, that whole concept of viability. In India, we are still going with 28 weeks. The British say 24 weeks, the Americans say 20 weeks. So this is a very funny period of time. So 24 to 28, I think most of us will not try to help that baby survive, because it may not survive, right?
We can't give an intact baby.
Yeah, so the only thing is we can say this is a second trimester, so we can use mifepristone and misoprostol. If she's ruptured membranes, misoprostol alone may also work. So that's what I would use.
That's it. Yeah. Okay, centrally acting ondansetron can be a choice rather than phenothiazine to prevent vomiting in icteric mother. Centrally acting.
I guess ondansetron is fine. Yeah.
Ondansetron is fine.
These were the questions which have been filtered and brought to us. So really,
I'll just say one thing about misoprostol before we cut off, because it does cause, it can cause fever, it can cause nausea, vomiting, and diarrhea. So what we did
also
fever. That's what. So in women, what we did was, before giving misoprostol, they always took a loperamide and an anti-nauseant before they came into the hospital. Then we gave them the misoprostol, so you avoid that severe nausea.
But do you experience so much with misoprostol?
Yes.
Every patient I have.
No, not every patient. Not every patient. But the thing is, if you give it to them, they are better off.
I think hyperpyrexia, that too, I mean,
repeated
the shorter duration we use higher dosages.
Repeated doses will.
Yeah.
Especially when you're talking of second trimester. I'm not talking of labor.
Yeah, second trimester.
Go ahead.
So here we come to end for the question session. It was really very interesting session. And now the points which I have collected, I would like to say, like Dr. Geeta has said, obesity is one more factor which has landed in the list of reasons for sepsis. Iatrogenic abortions, like we call septic as only illegal, but sometimes there are iatrogenic also abortions which lead to septic abortion in the case, or lead to septicemia. For infection prevention practice to be done, a very strong point by Dr. Poonam, and which should be their prevention to prevent sepsis and mortalities. Another very important point was by Dr. Geeta, tachypnea. Just a C and you have to raise an alarm. Tachypnea has to be given a very important point. All delegates are observing, the juniors, the upcoming people, tachypnea. Just give a very important note to tachypnea, and then you touch the patient, the pulse. It speaks a volume. So tachypnea and tachycardia, two very important indicators for a tool to know about the sepsis. Then hypoglycemia in patients with hepatitis or with hepatic
fatty liver.
This can be a cause for even neonatal mortality or even for mortality of mother. So you have to keep a check on her blood sugars also, along with her all profiles and all lab reports and all investigations. Then immunization. As Madam has said, if a patient is HBV positive and if her husband is negative, this I was not knowing, that 0, 1 and 2 doses have to be given to the husband, and protection is advised, and then he takes his 6th routine dose. Okay, one more important point by Dr. Sheila. When there is septic abortion, this uterus which is carrying a septic focus is refractory to uterotonics. Keep in mind, otherwise you keep on bombarding with pitocin and all ergometrin and everything, and the patient will land up in more problems. Dr. Geeta's favorite cocktail was cephalosporin, metrogyl and clindamycin to be tried in patient, right?
No, that's not my cocktail. I never use cocktail.
For a severe patient, before the reports come.
Sepsis.
Yeah, in a septic patient, before the report comes, this can be a good combination. Yeah. And really using this combination, because higher antibiotics are so frequently used that resistance has already come in. Now we are really in search of some new molecules.
These are the recommendations from guidelines. Yeah.
Okay. So now catheter. One more thing which we learned is you can remove catheter immediately after C-section. That's also a very good practice guideline. We can remove it or on the same day. Many times it is carried for 2 or 3 days. That can be changed. Proper catheterization is very important. That can prevent so many of infections and so many of pyelonephritis. Has to be taken care and should be guided for the new staff. Then again a new thing, that vaccination. Influenza vaccine can be given at the first visit. This we should incorporate in our protocols or in our practice. To put drain in patients who have dengue fever, because they have platelet pathology and they can bleed afterwards. So if a drain is kept in a patient who had a dengue positive, and she has to be taken for surgery. One more thing was told by Dr. Sheila was tablet mifepristone 200 milligram TDS for resistant cases for termination.
No, where the patient is febrile and you want to terminate, because misoprostol will again lead to hypothermia.
Yeah. So we can use mifepristone 200 milligram TDS. Okay. Hybrid labor room, a very good concept, Dr. Poonam. Really, people can try for those hybrid labor room, especially in this corona crisis. That is a good one. Madam has said cefazolin 1 dose prophylactically is sufficient. Only if there are cases of PPPROM, then you give 2 or 3 doses, right? Infection prevention practice to be stressed. If patient is with simple fever, wait and see with paracetamol, because many times without antibiotics it can come off, and then give appropriate antibiotics, which has to be learned by everybody, not only gynecologists, but everybody has to use antibiotics appropriately. And one more thing which has come out, that internal audits for near-miss cases has to be done to improve outcome and to have a healthy mother and a healthy nation, we can say. So finally, I am really thankful to all panelists. I'm thankful to Dr. Kanti and Dr. Lakshmi for sparing their time. I'm thankful to Dr. Parag, who has granted us with 1 credit point. I'm thankful to all delegates who have logged in today. 2,000 delegates have logged in for our program, and that's really a good one. I hope that you have all been had an advantage of joining this webinar. And
advantages of webinar. You are seen by so many people.
Yeah. Our next webinar will be on medical disorders, maternal near miss with medical disorders, which will be it's proposed to be on 5th September. We will let you know. So again, I request you all to be present there. And lastly, I'm thankful to Science Integra team. They have so meticulous in working. They have planned all this webinar so well, and execution was so well because of their inputs. Thank you all.
Well done.
Thank you.
Thank you. See you all. Bye.
Thank you.
Bye.
And
Thank you very much.
so many people are happy to see you, ma'am, today. All of you. Thank you, ma'am.
Thank you, Kanti. Thank you, Lakshmi, Poonam, Geeta, Pragati. Good. Well done.
Good to see you.